Achalasia is a rare disorder of the esophagus that affects its ability to move food toward the stomach. The esophagus is not just a simple tube, it's a sophisticated organ that plays a crucial role in the digestive process. When functioning correctly, the esophagus uses coordinated muscle contractions, known as peristalsis, to push food and liquids down towards the stomach. At the lower end of the esophagus, there's a specialized ring of muscle called the lower esophageal sphincter. This sphincter acts as a valve, relaxing to allow food to pass into the stomach and then tightening to prevent stomach contents from flowing back into the esophagus. In achalasia, two main problems occur. First, the nerve cells in the esophagus that control peristalsis become damaged or degenerate, leading to weak or uncoordinated muscle contractions. Second, the lower esophageal sphincter fails to relax properly when food approaches. As a result, food and liquids have difficulty passing through to the stomach, often becoming trapped in the esophagus. This can lead to a range of uncomfortable and potentially serious symptoms that significantly impact a person's quality of life. Achalasia is considered a rare disorder, with an estimated prevalence of about 10 cases per 100,000 individuals in the general population. This rarity often contributes to delayed diagnosis, as many doctors may not encounter the condition frequently in their practice. Causes of achalasia. The exact causes of achalasia remain somewhat of a mystery to medical researchers. However, several theories and potential contributing factors have been identified. One leading theory suggests that achalasia may be an autoimmune disorder, where the body's immune system mistakenly attacks and damages the nerves in the esophagus. This theory is supported by the presence of inflammatory cells in the esophageal tissue of some patients with achalasia. Genetic factors may also play a role in the development of achalasia. While the condition doesn't typically run in families, researchers have identified certain genetic variations that may increase an individual's susceptibility to the disorder. Some studies have suggested a possible link between viral infections and the onset of achalasia. Certain viruses, such as the herpes simplex virus, have been found in the esophageal tissue of some patients with achalasia. The theory is that these viral infections might trigger an autoimmune response or directly damage the nerves in the esophagus. Interestingly, achalasia shares some similarities with Chagas disease, which is a parasitic infection common in parts of South America. In Chagas disease, the parasite can damage the nerves controlling the esophagus, leading to symptoms similar to achalasia. This connection has led researchers to investigate whether other infectious agents might play a role in some cases of achalasia. Symptoms of achalasia. The symptoms of achalasia typically develop gradually over time, often progressing slowly over months or even years. This slow onset can sometimes lead to delays in diagnosis, as people may adapt to the changes or attribute them to other causes. The primary symptom of achalasia is difficulty swallowing, known medically as dysphagia. This isn't just a minor inconvenience. For many people with achalasia, the act of eating becomes a challenging and sometimes anxiety-inducing experience. Individuals with achalasia often describe the sensation of food sticking in their chest after swallowing. This feeling can be uncomfortable or even painful, and it may last for several minutes or even hours after eating. Many people find that they need to drink large amounts of water to help push food down into their stomachs. Some individuals develop specific techniques to help them swallow, such as lifting their arms above their head or standing up and walking around after meals. As the condition progresses, swallowing difficulties often extend to liquids as well as solids. This can lead to unintentional weight loss, as people may begin to eat less to avoid the discomfort associated with meals. In some cases, individuals may experience regurgitation of undigested food, sometimes even hours after eating. This can be particularly problematic at night, potentially leading to aspiration of food into the lungs, which can cause coughing, choking, or recurrent respiratory infections. Chest pain is another common symptom of achalasia. This pain can vary in intensity and character, ranging from a dull ache to sharp, stabbing sensations. Some people describe it as feeling like heartburn, which can sometimes lead to misdiagnosis as gastroesophageal reflux disease or GERD. The pain may be triggered by eating or drinking, but it can also occur spontaneously. Many individuals with achalasia also experience excessive salivation, particularly during meals. This is thought to be the body's attempt to lubricate the esophagus and help food pass through more easily. However, it can be embarrassing and uncomfortable for those affected. Before we continue, if you have been finding the video helpful so far, hit the like button and don't forget to subscribe and hit the bell icon so you don't miss more videos like this. Diagnosis of achalasia. Diagnosing achalasia can be challenging, as its symptoms can mimic those of other, more common digestive disorders. However, a combination of clinical evaluation and specialized tests can usually provide a definitive diagnosis. The process typically begins with your doctor asking you detailed questions about your symptoms, their duration, and any factors that seem to worsen or alleviate them. One of the key diagnostic tools for achalasia is a barium swallow study, also known as an esophagram. In this test, the patient swallows a liquid containing barium, which shows up on X-rays. As the barium moves through the esophagus, a series of X-ray images are taken. In people with achalasia, these images often show a characteristic bird's beak appearance at the lower end of the esophagus, where the LES fails to relax properly. The esophagus may also appear dilated or widened. Another crucial diagnostic test is esophageal manometry. This procedure involves passing a thin, flexible tube through the nose and down into the esophagus. The tube contains sensors that measure the pressure and coordination of muscle contractions in the esophagus. In achalasia, manometry typically shows weak or absent peristalsis in the body of the esophagus and incomplete relaxation of the LES. Endoscopy is often performed to rule out other conditions that might cause similar symptoms, such as esophageal cancer or strictures. During an endoscopy, a flexible tube with a camera is passed down the throat, allowing the doctor to visually inspect the lining of the esophagus and stomach. While endoscopy doesn't typically show specific signs of achalasia, it can help exclude other potential causes of symptoms. Treatment for achalasia. Once achalasia is diagnosed, treatment focuses on improving the passage of food through the esophagus by addressing the failure of the LES to relax properly. One of the most common treatments for achalasia is pneumatic dilation. In this procedure, a balloon is inserted into the esophagus and inflated at the level of the LES. The pressure from the balloon stretches and slightly tears the muscle fibers of the sphincter, allowing it to relax more easily. While effective, this procedure may need to be repeated over time as symptoms can recur. Another option is heller-myotomy, which is a surgical procedure that involves cutting the muscle fibers of the LES. This can be done through traditional open surgery or, more commonly, through a minimally invasive laparoscopic approach. Heller-myotomy is often combined with a partial fundoplication, which is a procedure that wraps part of the stomach around the lower esophagus to prevent reflux. In recent years, a newer technique called peroral endoscopic myotomy, POEM, has gained popularity. This procedure involves creating a tunnel in the wall of the esophagus through an endoscope and then cutting the muscle fibers of the LES. POEM has shown promising results and may offer advantages in terms of recovery time and reduced risk of reflux compared to other surgical options. For patients who are not good candidates for more invasive procedures, Botox injections into the LES can provide temporary relief. The Botox paralyzes the sphincter muscle, allowing it to relax. However, the effects typically wear off after several months, requiring repeated treatments. Medications such as calcium channel blockers or nitrates can sometimes be used to relax the LES. However, these are generally considered less effective than other treatments and are often used as a temporary measure or in patients who cannot undergo more definitive procedures. At the end, living with achalasia requires ongoing management and adaptation. Even after treatment, some individuals may need to make dietary modifications, such as eating smaller, more frequent meals and avoiding foods that are particularly difficult to swallow. Staying upright for some time after meals can help prevent regurgitation, especially at night. Now, we want to hear from you. Do you or someone you know have achalasia? What treatments did you have? Share with us your experiences and opinions in the comments below. We love to hear them. Thanks for watching.